ovarian endometriosis, and these figures are comparable to those for diagnostic laparoscopic surgery. Even to rectosigmoid endometriosis, the sensitivity and specificity of transvaginal ultrasound was 96 and 98.5% respectively, which was significantly higher than those of diagnostic laparoscopy. Major international guidelines recommended imaging tests such as MRI and ultrasound for the diagnosis of severe endometriosis and endometriomas. However, some still require diagnostic laparoscopy for definitive diagnosis and treatment in the past. But it's time to change the paradigm of endometriosis diagnosis. Laparoscopic diagnosis of endometriosis has resulted in prolonged delay between symptom onset and diagnosis and subsequent treatment. To solve the problem, endometriosis diagnosis should be based on a combination of patient history, clinical examination, and imaging study. But this change will enable patient-centered rather than disease-centered treatment. This change can reduce the delay in time to diagnosis, bring rapid relief to affected patients, limit disease progression, and prevent sequelae due to disease progression. Laparoscopic diagnosis is no longer the gold standard in the diagnosis of endometriosis. It's only recommended in patients with negative imaging results and in patients with that empirical treatment was unsuccessful. When a patient complains a symptom and sign related to endometriosis, the doctor performs a clinical examination and ultrasound examination. If the patient has sign of endometriosis, doctor can proceed to treatment of endometriosis without diagnostic laparoscopy. Even if the patient has no definite sign of endometriosis, the doctor may start empirical medical therapy. If the patient responds, doctor may maintain the treatment. Next is the paradigm shift in treatment of endometriosis. Another Korean zombie movie, Train to Busan. Have you seen this movie? Okay, here is Busan and here is Seoul. The main character runs away from Seoul to Busan to avoid zombie. Endometriosis is a zombie disease. It chases patients anywhere, anytime. Symptoms related to endometriosis can be treated with either medical treatment or surgical treatment. There is no superiority between the two treatment methods. For medical treatment, there are several different hormone approaches, including progestin, oral contraceptive, and GnRH agonist. So the pros and cons of each treatment and individual patient condition, for example, patient treatment preference, treatment efficacy, and side effect and treatment cost and availability should be fully discussed and decided together. In the past, CN treatment approach is preferred management for the endometriosis. Surgical approach is very crucial for the diagnosis and treatment for endometriosis. Therefore, most patients should undergo surgery first for the definite diagnosis and treatment. This approach results in decreased ovarian function and recurrence. In 2023, our group reported the long-term follow-up more than 5 years results of our endometriosis patients. From total 2,484 endometriosis patients, 756 patients with stage 3 or 4 endometriosis who were followed for more than 5 years in our hospital were included in this study. Of these 756 patients, 211 patients relapsed. The cumulative recurrence rate at 2, 3, 5, and 10 years after surgical removal of endometrium were 5.8%, 8.7%, 15.5%, and 37.6% respectively. The cumulative reoperation rates at 2, 3, 5, and 10 years were 0.1, 0.5, 2.9, and 15.1% respectively. The shorter period of post-operative hormone therapy the higher the recurrence rate. Less than 24 months group recurred very quickly, even within 12 months. In 24 to 60 months treatment group, relapses increased from 24 months after they stopped taking the medication. More than 60 months treatment group remained at low relapse rate. Hormone therapy acts like a prison that holds zombies in. If you stop taking hormone therapy, the zombies will come out of the prison. Even after the first surgery, disease recurrence remains a formidable challenge in the treatment of endometriosis. Clinical recurrence rate was 9% for 4 years after surgery and 28% for 8 years after surgery. However, if the pain included in the definition of relapse, the recurrence rates reach from 20.5% for 4 years after surgery and 43.5% for 8 years after surgery. Following the surgery, recurrence of the disease might be still noticed, which will progressively increase as time goes by. Another problem is that the surgery reduces ovarian function. Compared with the first surgery, there was a significant decrease in both antral follicle count and ovarian volume after the second surgery. In addition, after second surgery, the conception rate decreased to 22%. To prevent disease recurrence after surgery, post-operative hormonal suppression is still essential. This table shows the risk of endometriosis recurrence with post-operative hormonal suppression compared to the control. Oral contraceptive and progestin agents are recommended as the first-line treatment after surgery. Post-operative progestin treatment showed a trend towards decreasing risk of endometriosis recurrence by 83% compared to placebo. Surgical treatment of endometriosis-related pain can be considered with patients do not respond to medical treatment. And in situations where the doctor cannot exclude the possibility of cancer, surgical management is a treatment approach for endometriosis. However, the patient with pelvic pain and no desire for immediate pregnancy, long-term medical treatment should be considered as the first-line therapy. The long-term medical treatment can help patients maintain fertility and alleviate pain as the first-line therapy. After surgery, the long-term medical treatment can reduce unnecessary surgeries and the risk of disease recurrence. Many guidelines advise that endometriosis management should be tailored to individual patient's need, which is related to fertility. In case of endometriosis with no immediate desire for pregnancy, if the patient complains pelvic pain and dysmenorrhea, progestin and combined oral contraceptives should be considered as the first-line treatment. If medical treatment fails, then surgical treatment should be considered. However, surgery should be performed only once during a patient's whole treatment process, if possible. If the patient with endometrioma does not complain of any symptom, either expectant management or medical treatment can be tried. 2022 ASHRAE guideline recommends progestogen and combined oral contraceptive as the first-line medication. GnRH agonist is no longer first-line choice. GnRH agonist is recommended as a second-line therapy due to the concern about side effects which make long-term treatment difficult. Vijan is selective progesterone receptor agonist with both central and local effects. It inhibits gonadotropin secretion and suppress of circulating estradiol and inhibit ovulation centrally. Vijan also anti-proliferative, anti-inflammatory, and anti-angiogenic effects and local endometrial tissues. And several studies have proved that Vijan significantly reduced the volume of endometrioma. After 6 months of Visan treatment, her endometriosis cyst volume and diameter reduced up to 40%. Post-operative Visan treatment reduced endometriosis recurrence significantly. The meta-analysis by Zachary reported the incidence rate of endometriosis recurrence in patients treated with DNOGAST 2 per 100 women over a mean follow-up of 29 months versus 29 recurrence per 100 women managed expectantly over 36 months. Many studies have proven the efficacy and safety of Visan for the treatment of endometriosis, especially ENVISION study proves the improvement of quality of life in more than 800 Asian women prospectively. BIPOS study included more than 25 data reported that 798 patients received Visan treatment more than 15 months, and there was no serious adverse event in users treated with Visan. Even there was no difference in side effects between the patients who received Visan more than 7 years and those who took the Visan for a short period of time. The next treatment trends of endometriosis by Korea. So according to Korean health insurance data, the number of patients diagnosed with endometriosis increased by approximately 65% from 2018 to 2023. Especially, Visan prescription rate rapidly increased from 12.1% in 2013 and 36% in 2019. Due to national health insurance coverage change, surgery rates decreased to 60.3% to 12.7% in 2019. The use of GnRH agonists decreased rapidly from 33.6% in 2010 to 16.4% in 2019. The decreased surgery rate was significant in endometriosis patients under the age of 40 years. This is thought to be due to the fact that many women under the age of 40 are planning to become pregnant in the future. So while the use of total hormone therapy and Visan increased in all age groups, the increase was greater in those under 40 years of age. So the Korean Society of Endometriosis updated the clinical guideline for the treatment of endometriosis in 2024. Korean guidelines strongly recommends to check ultrasound to confirm or to exclude ovarian endometrium in patients who are suspected to have endometriosis. As you can see, the surgery can be considered when malignancy cannot be excluded. Endometrioma is large and endometriosis affect the other organs such as bowel and urinary tract. If the patient does not have plan to become pregnant, then long-term medical treatment should be the first-line treatment instead of surgery. Okay, I'm gonna share my experience with 3 cases. The first one, a 34-year-old woman visited my clinic on 2018. She had not married yet. She complained dysmenorrhea and 2.6 centimeter left ovarian cyst was identified on pelvic ultrasound. Say 125 and Roma was normal, and AMH level was 2.02 nanogram per milliliter. So I recommended oral contraceptive first. She refused the hormonal treatment. After 3 months later, left ovarian cyst grew to 3.9 centimeter, and she disappeared. And 2 years later, she reappeared with 4.2 centimeter left ovarian cyst, and her symptom aggravated. She was recommended to receive the hormone treatment again, but she refused and disappeared again. Another 2 years later, in 2022, she reappeared again after marriage with the 6.2 centimeter left ovarian cyst and a new developed left tubal hydrosalpinx. She complains dysmenorrhea and AMH dropped to 0.89. She did not have planned to get a baby. She was recommended to take Bijan. And finally, she listened to me and started to take Bijan. 6 months after taking Bijan, her left ovarian cyst decreased to 1.7 centimeter, and dysmenorrhea improved. In 1 year later, taking Bijan, left ovarian cyst was only 0.8 centimeter. Okay, this is case 2. Single woman, an unmarried woman visited my clinic in 2019. The patient had past history of bilateral endometrioma in 2017. At that time, she underwent laparoscopic bilateral ovarian cyst enucleation and received hormonal treatment with GnRH agonist for 6 months in another hospital. She had a symptom of pelvic pain and dysmenorrhea and visited another hospital where she was diagnosed with bilateral ovarian endometrioma again. Right ovary was 5.2 centimeter, as you can see here. Left ovary was 3.2 centimeter. She was advised to have surgery. Her CA-125 level was elevated to 75.2, and Roma was high risk, 15.6%. AMH level was 2.37. So she visited my clinic with this state. So I recommend Bijan first to prevent ovarian dysfunction from second surgery. After 6 months of Bijan treatment, her right ovarian cyst decreased from 5.2 centimeter to 3.5 centimeter, and left ovarian cyst from 3.2 centimeter to 2.6 centimeter. She's still taking Bijan. In 2022, her bone densitometry was normal. In 2023, she married, and her right ovarian cyst was 1.9 centimeter, and left ovarian cyst was only 5 millimeter. This is the case that we have to pay attention. She visited my clinic on June 2023. She was unmarried and had no medical surgical history. She did not have any symptom. She was diagnosed with 5.3 centimeter right ovarian endometrioma in other hospital and recommended to take Bijan first. She visited my clinic to get second opinion, and I encouraged to take Bijan continuously. 3 months later, the ovarian cyst grew more to 6 centimeter. I recommended surgery and conducted single port right ovarian cyst enucleation. Her pathology was mucinous cyst adenoma. So, okay, this is the last slide. Diagnostic laparoscopy is no longer gold standard for the diagnosis of endometriosis. Please use imaging tests more actively to diagnose endometriosis. Modern endometriosis management should be individualized with a patient-centered, not a disease-centered. And long-term hormonal treatment, including Bijan, should be considered as first-line treatment for the endometriosis patients. Bijan is effective and safe first-line option for endometriosis. Consider that surgery should be done once during the entire endometriosis life to save the woman's ovary. Thank you for your attention.
Thank you. Hello. Yeah. Thank you.
Yeah.
Dr.
Yeah.
Tong.
Yeah. I can hear you.
You can hear me. I think that would you will have a few questions from the fellow to ask you. I think shall we leave it until Dr. Yun finish his talk. Maybe a few questions, then you two can answer all together, right? So can you bear with us a minute? So let's have the PM Yun, Dr. Yun, to talk to us about the long-term medical treatment and latest clinical experience with endometriosis in Hong Kong. So PM, please start your talk.
Yeah, thank you very much, Katie, for the kind introduction. So what I'm going to talk about today is basically on the long-term medical treatment. They only refer some of this clinical experience, only refer my own experience. It may not totally refer what is the real situation in Hong Kong. Okay. So as mentioned by Professor Chung, having endometriosis is a chronic disease and it requires long-term medical treatment. This is because endometriosis is well known to be associated with high recurrency rates after surgery. This was mentioned to be about 20% after 2 years of surgery and about 50% after 5 years. So the whole main aim of the medical treatment is to minimize the risk of disease recurrency and to control the residual symptoms and also the residual disease after the surgery. Hopefully, we can control the widespread systematic effect of endometriosis and reduce the need for subsequent surgery. And in fact, post-operative hormonal suppression has been found to be effective in reducing the endometriosis recurrency and also improvement in the pelvic pain associated with the endometriosis. This can result in a significant decrease in the risk of endometriosis recurrency with a relative risk of 0.04 and also a significant reduction in the pain score with an SMT of -0.45. When pregnancy is not decided, post-operative long-term hormonal treatment is recommended for the secondary prevention of endometrioma and also endometriosis-associated symptom recurrency. Back in 2022, a group of doctors or clinicians with experience in endometriosis from Asia and Europe actually grouped together and reviewed the international guidelines and the consensus agreement and draw a consensus for the Asia expert group on the early medical management for endometriosis. What they want to say is that a definitive diagnosis is not required before commencement of treatment, as mentioned by Professor Chung. And also medical treatment is recommended to reduce endometriosis-associated pelvic pain. And hormonal treatment is more effective option than the other choices, and progestin actually are recommended as the first-line medical management for early medical treatment. And oral progestin-based treatment actually is considered to be better option as compared to the compounded oral contraceptive pills because of the safety profile. And there's a large evidence base exists supporting the use of diinogest compared with the GnRH analog as the first-line medical treatment. And GnRH analog may be considered a first-line therapy only in some specific situation, or sometimes we use it short-term before the starting of the diinogest. And diinogest can be used lifelong if needed. And that diinogest is the fourth generation selective progesterone. It is a 19-non-testosterone derivative. It has the anti-proliferative, anti-inflammatory, and anti-angiogenic effect specific to the endometriotic cells. Concurrently, it also moderated the reduction in the estrogen production, and also it inhibits the ovulation from the ovary. This will result in a significant improvement in endometriosis-related symptoms, and also a reduction in the endometriotic cyst diameter and volume. Currently, the longest reported I can identify reported the effectiveness up to 7 years after the treatment with a good control of the symptoms, also reduction in the endometrioma, and at the same time preventing the recurrence of the disease. And I think Dr. Professor Chung has already touched on the effectiveness, and there are a number of studies reporting the effectiveness on pain relief, lesion reduction, and post-operative recurrency. But most of the study were confined probably within the first 36 or first few years, and there's only a limited paper that actually have long-term study over the years, over 5 or 6 years time. And based on the system systematic review and meta-analysis, it was found that the incident rates of endometriosis recurrency in patients treated with diinogest was only 2% compared with the 29% in the control group. And the incidence of endometrioma recurrence was also down to 2%. So this has become a very effective way of controlling the disease. And the likelihood of recurrent endometriosis was also significantly reduced with the postoperative diinogest treatment. In the 2023 meta-analysis, the one study showing that the diinogest is associated with the reduction of the pelvic pain compared with the placebo up to the more than 24 months after the treatment. And also, the meta-analysis showed that the GnRH can cause a significant reduction in the uterine volume, but not the other hormones. And the other hormone which showed no significant difference in the uterine volume. And from the meta-analysis, it was said that the COC are less effective in comparing with the GnRH, with the Mirena, and also the Diinogest, basically because of the shorter number of bleeding days associated with the two progestogen medications. And we all know that Diinogest is also very safe. Looking at the report study, which is the stand for the recent post-approval observational study, recruiting over 27,000 women with about 3,000 something women taking the Diinogest, following them up for 18 months, suggesting that there's no safety signal regarding serious adverse event associated with Diinogest, and it is safe and tolerable without increased risk of serious complications. If you're looking at the systematic review of the adverse effect of Diinogest, most adverse reactions are relatively common, but they are not usually not serious. And the most common adverse reaction are abnormal uterine bleeding, amenorrhea, swelling, and also headache. Similarly, a large prospective cohort study also showed that the adverse effect of Diinogest is abnormal uterine bleeding, increased weight, and headache. And the number of patients with favorable bleeding pattern was observed to increase as the duration of treatment increases. So the problem with the abnormal uterine bleeding usually will resolve spontaneously with time. And the study also showed that amenorrhea was observed in about 30% of women, up to over 50% when we follow them up from 3 months to over a 12-month period. So with time, the amenorrhea rate was also increased. And this I would not consider as an adverse effect. I think this is a good result as we felt from the drug effect on the endometriosis. You can see the number of bleeding episodes actually decreased with time, and when we progressively, when we continue with the medical treatment. And the bleeding intensity also decreased during the long-term Diinogest treatment. And the percentage of patients with irregular and intermenstrual bleeding increased during the first 6 months and returned to the baseline level at around 24 months, basically 2 years after the treatment. Another issue people will worry about is the use of the hormone in relation to the breast cancer. And in fact, I think most of us are aware that the use of estrogen alone usually presents either a small increased risk or low increased risk of breast cancer. And the combination of estrogen with progesterone or dydrogesterone associated with no or less and non-statistically significant increase in the risk of breast cancer. However, if estrogen is combined with progesterone, there will be an increased risk of breast cancer, but not when it is combined with progesterone or dydrogesterone. So it's suggesting that the use of progesterone may be increased with the risk of breast cancer with the prolonged use. However, based on the report from or guideline from the Faculty of Sexual and Reproductive Healthcare, is suggesting that the use of the progesterone-only pills has not been shown to increase the risk of breast cancer. And there's no evidence association with the two with the breast cancer. So the effect of Diinogest on breast cancer has not been fully reported. And I think at the present moment, there's no case report claiming that the Diinogest is associated with the increased risk of breast cancer. In fact, a study done in Taiwan reported in 2023, and there's a retrospective study looking at over 1,000 patients receiving Diinogest for up to 60 months. And they reviewed breast screening and examination, and they found out that there's no association between Diinogest and breast cancer. And among all the patients on the examination, they can only find 19 cases with the Burford lesions And there's only one case of invasive carcinoma. So there's actually no evidence to say that breast dienogen is associated with the occurrence of the breast cancer. And then the issue people will worry about the prolonged use of the dienogen is on the bone loss, resulting in osteopenia and even osteoporosis. If you look at the literature, there's two randomized studies comparing the dienogen with the GnRH analog, which was conducted in Japan and Europe, up to 24 weeks of treatment, and looking at the bone density changes. And in the Japanese study, which is shown in the blue line here in the graph, both the dienogen and the buserelin, which was the GnRH analog being used, have been shown to reduce the bone loss after 24 weeks, but the reduction is only talking for the GnRH analog is about 2.6%, but with the dienogen it's much less, it's only about 1%. So it's not a major reduction in the bone loss. And the European study also showed something similar with the rapid reduction of the bone loss in the GnRH analog group, but with the dienogen, there's actually not much improvement. In fact, there's a study higher than the baseline. So the use of the dienogen may decrease the BMD in Asian women, but may not be so in the European women. So you look at even a longer duration of treatment. So there were two studies, which was a multi-center study, both in Japan and Europe, looking at the treatment up to 1 year. And the Japanese study showed that the BMD at 24 weeks and also at 1 year actually is significantly lower than the baseline. However, there's no significant change from the 24 weeks to 52 weeks in terms of the bone minimal loss, suggesting that the drop only occurred in the initial 24 weeks, but subsequently the loss will be flattened, and there may be no significant decrease afterwards. And in the European study, which basically based on the adolescent girl, and they also found that by 1 year there was a significant drop in the BMD, but once the medication is stopped, and within 6 months, and there's some recovery of the bone minimal density, right? And so it seems that the bone density will recover once you stop the medication, especially in the adolescent group. There are two studies published in China, which is a randomized study comparing the dienogen with the placebo, and followed up by an extension study on putting all these patients in with the dienogen. And what they found that there is actually, although there's a slight decrease in the bone density at 24 and 52 weeks, it is not statistically significant. And they concluded that there's actually no significant detrimental effect on the bone mineral density in the Chinese group when we follow up for them for 1 year. So it seems that there is a racial or ethnic difference in response to the dienogen with regard to the bone minimal density loss. This is further proven so that by these two studies published in Korea in 2017 and 2021, when they follow up the patient from the first 1 year and another review after 3 years follow up. So after completion of 1 year follow up, they found that the bone density for the lumbar spine dropped for about 2.7%, and for the femur neck it dropped about 2.8%. So with a larger number, the second study with a larger number of patients, they found out that the lumbar spine actually dropped up for 2.7%, and also for the femur it drops only about 1.6%. With longer follow-up after completion, after 4 years, they found out that the lumbar spine BMD dropped about 4.4%, and the lumbar spine femur leg dropped about 3.6%. So only within 3 years of time, the drop is talking about 4%. This is similar to the effect of GnRH analog, causing the drop in the BMD, but this happened with the GnRH analog usually occurred in about 6 months' time, as in compared with the diinogers, which takes 3 years to have similar effect. So it seems that the effect of BMD varies with diinogers on different populations, and although most of the study were confined to the first year of use, right? And the BMD decrease predominantly occur in the first 6 to 12 months of the treatment, and the loss gradually decreased with time during the course of treatment. And in adolescent, there is a partial recovery of the BMD when we stop the medication in the first 6 months after we stop the medication. And the extent of the impact of BMDs is no greater than that of the GnRH analog. And also, as I mentioned, there seems to be some average difference related to this. This may be related to the serum estradiol level in different population and age. Also, actually, is an important factor related to the decrease in BMD. So this is a multiple factorial things. And so at the present moment, I think that there might be some decrease in the BMD, but with the long-term treatment, it doesn't seem that there will be a major significant loss. We have to wait for more data to come. So I'm going to share my experience as well. For a few cases, if times allow. So the first case is the patient, a single 40 years old. She presented with heavy period dysmenorrhea and ovarian cysts about 12 years ago, and with severe amenorrhea. And she underwent the bilateral ovarian cystectomy for endometriosis and a myomectomy for small fibroid back in 2011. And after the treatment, she was put on GnRH analog, and then her symptom seems to improve after operation and the treatment. However, those heavy period and dysmenorrhea recur, and she subsequently also developed posterior adenomyosis starting from May 2012. Because of that, she was put on the Visan treatment since June 2013, and she became amenorrhea since October 2013 with very occasional spotting. And ultrasound showed they're stable. Adenomyosis around 5 centimeters, and the usual fibroid also something like around 5 centimeters. And the last ultrasound scan was done actually in June this year, which reflect the stable situation. And the patient actually have a few bone mineral density done, as shown here. So the first one was done 6 years after starting the Visan, and we saw that she is the first dot here. So that the patient was actually with very significant osteopenia, almost up to the stage of osteoporosis, with a Z-score of 2.1 and 1.4. And however, when she had another BMD done 8 years and 11 years later, there is increase in the bone density in both the femur leg and also the lumbar spine, resulting in a slight improvement in the BMD in the Z-score. And at 11 years, it seems to stable after that from 8 years to 11 years. The patient still having, although it's still osteopenic, but there's no further deterioration. And one thing is that the first scan actually was done in a different institute as compared to the last two BMD. So whether there is a difference in the result from these two laboratories, I'm not sure. But at least from the last two results, which show, seems to have a stable BMD without a significant change over a 3 years period. Second patient is the patient 41 years old. She was basically asymptomatic, but was found to have bilateral ovarian chocolate cyst with also have pelvic endometriosis. Underwent operation in August 2013, and because of she want to have the prevention of the recurrence of the endometriosis, she agreed to start up on the Visan shortly after the operation. And she responded very well with the medication, with no period spotting and no other complication. and she was continuing on the medication for almost 11 years now. And ultrasound, we were actually no recurrence. And she also had 3 episodes of BMD being tested at 4 years, 8 years, and 11 years after the procedures, showing that she has a normal BMD with very stable, with no significant change over all this year. Right. The only thing is we don't know before what is the her baseline before we started the medication. Right? Because at the present moment, at the beginning, based on the early study, we don't think that there is an effect. So I didn't do the BMD at the beginning of the year, only until after 4 years. Right? But I mean, it seems that in this case, the long-term treatment with the just doesn't seem to have significant effect on her. So the third patient also have been taking the diagnosis for 11 years. She is currently now 51 years old. She presented with heavy and painful period for 2 years and found to have ovarian chocolate cyst, which was removed together with the excision of pelvic endometriosis back in 2011. And at the time that she actually was diagnosed to have adenomyosis as well. And she was put on the G-angio analog for 6 months, and her period became slightly heavier and painful afterwards. And after stopping the medication, and the condition used, and with time it was getting worse, and the adenomyosis also increased in size. And so by October 2013, I started her on the Visant, and the pain resolved. And initially she had a regular period and some period spotting. And since 2015 March, she actually have no more period and just occasional spotting. And after starting the Visant, the adenomyosis stable at about 5 centimeters, and she's happy with that. And we're planning to stop the Visant at the age of 52. Hopefully, she has already reached menopause by then. And she also had 2 episodes of the bone marrow BMD being performed 6 years and 10 years after the starting of the GNRH analog, after starting the diagnosis. And the Z score basically doesn't change much. For the female, the Z score actually increased from -0.4 to -0.3. But for the lumbar, it drops from -0.4 to -0.6. And in fact, she actually maintained very good, relatively good bone mineral density. So I guess, she basically have a normal bone mineral density, at least from year 6 to year 10. So again, this is a second example that, it seems that the long-term treatment with the diagnosis, there is no significant change in the BMD over the years. The third case, she took Visant for only about less than 7 years. She is 29 years old with the right ovarian cystectomy for chocolate cyst and excision of the pelvic endometriosis in August 2016, and she was put on Visant postoperatively, also for the prevention, mainly for the prevention of the recurrence of the endometriosis. And again, she have no period, and although period spotting, and she had 1 episode of the BMD being done 4 years after starting the medication, and the BMD showed that she was actually osteopenic at the moment, and at that time she was only 22 or 23. But this is not surprising in Hong Kong, because it's quite well known that the young girl in Hong Kong, not a young girl in Hong Kong, actually is osteopenic. Because they have less exercise, they have they avoid exposure to the sun, and they are relatively thin. So they are more likely to develop the osteopenia. And in May 2022, she actually had a second operation for the left right ovarian cyst, and this time this is a dermoid cyst. And when we go in, and this is the situation at the time, which I can manage to find the pictures, and you can see the whole pelvis looks pretty normal, and there's no evidence of endometriosis at that time. And the patient actually continued to make the medication until 2022, when she started planning for the pregnancy. And once she stopped the medication, she's almost got pregnant after 2 months when she had the period returned. And she had a very successful pregnancy, and she have a cesarean section in 2023 with a healthy baby. So this is a very good example that the use of the dienogest or hormonal treatment for the prevention of the endometriosis, and actually the medication probably will help to some of the endometriotic deposit to regress, resulting in a relatively normal looking pelvis. The fifth case is the patient who had received 8 years of the dienogest. She is 48 years old. She presented with postmenstrual pain, mild dysmenorrhea, and intermenstrual bleeding. And she had the left laparoscopic left oophorectomy and myomectomy performed in 2010. And because she has a large complex endometriotic cyst with very severe lateral adhesions. And at the time, she was advised for post-operative hormonal treatment, but she was reluctant to undergo the treatment and basically adopted expected management. And she developed a recurrence of the disease and the chocolate cyst and underwent operation in 2016, together with the removal of some of the fibroids. And also she has some small adenomyoma, which also removed together with the pelvic endometriosis. And after that, she was put on the Resant to hopefully to reduce the recurrency because she's afraid of losing her other ovaries. And she was stated to have a regular period, but presented with a frequent prolonged spotting and headache, which is maybe the side effect from the dienogest. And I thought and advised her to, in that case, she was advised to take the Resant cyclically instead of regularly every 24 days or every 4 weeks. So I asked her to stop the medication for 7 days every month, so that she will have a withdrawal bleeding. And in fact, you stopped the Resant for 5 days every 3 to 4 weeks when she had the prolonged spotting. And after that, her period become more regular, and then the spotting become less, and so her period also become less heavy, and she doesn't have any pelvic pain, and then less frequent to have the headache. And she is happy with now to continue with the Resant, and then she's going to continue, and ultrasound showed that there's no evidence of recurrence of the disease. And she had she had a BMD done recently showing that the lumbar spine actually is normal, and she has osteopenia with the femur. So although she has been taking it for almost 7 years, it doesn't seem to have much effect on her bone mineral density. The sixth case is the patient 37. She had a heavy and painful period with operation done in 2016. She also had adenomyosis, and also the dermoid cyst being removed. And initially, she was put on combined oral contraceptive pills after the procedure, but her dysmenorrhea persists. And so much so that eventually we switched to Resant in October 2016. And after that, she developed amenorrhea. She had no pain and she had no other symptoms. And she stopped the Resant in July 2017 and in preparing for pregnancy, which she eventually got pregnant and had a cesarean section in 2019. And after delivery, dysmenorrhea returns, and she wanted to use the oral contraceptive pills and tried it on the microgynon, which failed to control her disease, the symptoms. And eventually she was put back on the Resant in August 2020. And she developed amenorrhea again, and she was pain-free, and she now is happy with the situation. And recent ultrasound showed that the posterior adenomyosis is slightly bigger than before, but it's relatively stable, and the ovary was normal. Case 7 is a very interesting case. She is 45 now, and again, she presented with heavy painful period, but no urinary symptom. And in fact, she was diagnosed to have the anterior adenomyosis, about 5 centimeters, together with bladder endometriosis, about 2.5 centimeters, but she never have urinary symptoms. And because she refused surgery, and she basically put on the Resant since June 2016, and she have no period, and also symptom was completely controlled. And the adenomyosis seemed to shrink a little bit, but the bladder endometriosis stable at around 2.2 or 2.5 centimeter. However, about 2 years, 1.5 years after the treatment with Visan, she somehow, wanted to stop the medication and want to try the herbal medicine, which is a very common phenomenon in Chinese movement and Hong Kong people who want to take herbal medicine. However, after switching to herbal medicine, she developed gradually with heavy and painful period, and the adenomyosis grew back, and the uterus actually increased in size back to the original size. And she was actually in distress and coming back to see me in January 2020. We put her back on the Visant. And again, she developed amenorrhea, and the pain was completely controlled afterwards. And ultrasound 6 in June this year showed that the adenomyosis stays something like about 5.6 centimeter, and the adenomyosis in the endometriosis in the bladder stays something like about 2.5 centimeters. And she had 2 bone mineral density done, showing that she was a little bit normal initially with the femur leg, but for the lumbar spine, initially they was lower, but the second one she seemed to have a slightly increase with the BMD afterwards. And again, this showed that the long-term treatment with the just in the long term doesn't seem to have significant change in the BMD level after the medication. So lastly is also a patient with the mainly with the adenomyosis without any surgery done. She presented with the heavy and painful period with the anterior adenomyosis and failed with the compound oral contraceptive pills. And at that time, because she wanted to get pregnant, I actually put her on the GnRH analog for 6 months to try to shrink the fibroid together with the EPIT therapy. And then afterwards, she had the adenomyosis shrunk, and she basically undergo IVF and almost immediately get pregnant and have a normal cesarean section in 2017. And when her period returned, she started to have the heavy and painful period again, and adenomyosis increasing in size, and that's why I put her on the just in 2018 to 18, and she developed amenorrhea and also no pain, and the adenomyosis shrunk and stable at about 5 centimeters. And she stopped the medication again in July 2022 because she wanted to get pregnant, and she had a frozen embryo transfer. And again, she almost immediately get pregnant and having